Thank you. Thank you, Anuja, for that kind introduction. I just want to make sure what I'm going to do. I know there's probably feedback now because I'm talking into the phone, and also um, perhaps you guys are hearing me through. All right, perfect. So if you could do me a favor, just keep your phone. If there's a problem with the Wi-Fi connection or anything like that, then just let me know on my phone. And then what I'll do, you can send me a text, and then what I'll do is I'll just adjust here accordingly. So if I talk out loud, the sound is okay here. I'm in the airport, as you guys know. All right, perfect. All right, so I'll get started with the risk of looking silly with my phone here. I'm going to set it down and then just have Anuja text me if there's a problem. So thank you so much for allowing me to present tonight. I also it's sort of not out of the ordinary for global surgeons and surgical system scientists, as Anuja and Mike tonight had to adjust a little bit. Thank you so much for adjusting with my schedule. I'm flying back to Newark because of call I have to get back to tonight, and also a meeting tomorrow and Sunday. So thank you so much. Tonight I want to talk about achieving universal health coverage through national surgical system strengthening. And we do this and contextualize this through a Colombian situation analysis. I'm going to thank Dr. Joseph Hanna, who is one of my colleagues. He and I were hired 6 years ago at Rutgers in the Division of Acute Care Surgery. Gabriel Herrera, who is our partner at Santa Fe in Bogota, Colombia. We've been working with him now for just about over 2 years, and many other folks in Colombia for a total of about 7 years now. And there's other folks that I'd like to thank at Rutgers and really frankly across Colombia, and to include the Ministry of Health with all of the work that I'm about to present to you. So having said that, a couple disclosures and funding. I know that funding in global surgery is a little bit of a challenge for us. And I had earlier conversation with one of the engineering students about trying to understand what not only our value is, but what value is the care that we provide in the surgical obstetrics and anesthesia community. What are the health services we provide? So I think trying to understand some of the healthcare service value we provide, we're also trying to understand our value. And I think as we are able to secure more funding, we're able to do more things like this reverse innovation and learn from our folks across seas and in other countries, and especially in South America, with many of the problems that we have in North America today that do include problems that we're facing with value in the healthcare system, trying to understand how we balance costs with the quality of healthcare. Tonight, I'm going to talk with you about a Colombian surgical system preparedness, a Colombian surgical system service delivery, a Colombian surgical system cost protection, and the convergence and augmentation of the Ministry of Health's assessment. And then we'll summarize what we share tonight. Some of this may be new to some folks. It may be review, but all of the situational analysis that we do in the surgical system was based on some early literature in 2015. In Global Surgery 2030, a landmark publication by John Mira and other folks that reached consensus on trying to understand what would be the metrics to understand the health of a surgical system. And in other words, if you look at access to timely essential surgery, if you look at specialist surgical workforce density, if you look at surgical volume, and you look at perioperative mortality, and then a third category of protecting the patients that you care for that undergo surgery against impoverishing expenditure and against catastrophic expenditure. Those 6 indicators to the left there represent 3 sections of what makes up a surgical healthcare system. And when we say surgical healthcare system in the global surgery world, in the academic global surgery world, we're referring to surgery, anesthesia, obstetrics, and other services now. But for the most part, in this 2030 publication, we were referring to surgery, obstetrics, anesthesia, healthcare services provided. Now, if you look at the definitions of these 6 indicators, access to timely essential surgery is the proportion of the population that's able to reach a healthcare facility within 2 hours. There's a target of 80% of the population in which you study. By 2030, you want to reach that 80% of coverage. If you look at indicator 2, specialist surgical workforce density, that's the number of surgeons, anesthesiologists, obstetricians per 100,000 population. The goal for 2030 is that 100% of surgeons, obstetrics, and anesthesia in countries would at least have 20 SAO, or surgeons, anesthesiologists, and obstetricians. And what this really is workforce that addresses the population's need with respect to surgical disease. The third indicator, surgical volume. The fourth indicator, perioperative mortality. Surgical volume as indicator number 3 is how many surgeries are being performed per 100,000 population. And then 80% of countries by 2020 and 5,000 procedures per 100,000 population by the year 2030 are the goals for surgical volume. Perioperative mortality is really all-cause death, non-risk adjusted, after any surgery 30 days within the hospital. And the target is by 2030 that each country would have their own national target for considering how much perioperative mortality the healthcare system in that particular location should have. And then the 5th and 6th indicators, protection against impoverishing expenditure and protection against catastrophic expenditure, is as we as professional surgeons, obstetricians, anesthesiologists are providing healthcare services, what is the proportion of the population that then experiences impoverishing and catastrophic expenditure after we provide healthcare services? Now, in other countries, there's high risks of people becoming poor just as the result of having any surgical service provided for them. Now, you see by 2030, both indicators 5 and 6, there should be 100% protection against impoverishing or catastrophic expenditure as a result of any surgical healthcare service provided. So they are lofty goals that the Lancet Commission on Global Surgery and the Consensus Group set for us in 2015 with this publication for goals of 2020 and 2030. That's a large overview. With those 3 brackets to the left, we start saying, well, where did this come from? There was global policy right around that same time that in the first time in surgical obstetrics and anesthesia professions, the World Health Organization called for strategic plans that would aim to provide timely, quality, and affordable emergency and essential healthcare services for all people. So that gets at timeliness, quality, and affordability, which were these 6 indicators and those 3 sections in the description. And there was finally a World Health Assembly Resolution 6815 that prompted all members of the UN and countries to participate in these strategic plans. And then furthermore, in 2016, WHA Resolution 7022 took a step further and said that strategic plans aimed at timely, quality, and affordable emergency and essential surgical healthcare services for all not only need to have, in fact, plans in place, but there needs to be implementation for those plans. This is the only global policy that exists with respect to surgical healthcare services across the globe. They've built on that. And there were some messages right around that same time that was sent across the world as well as a result of this publication. 5 key messages to be exact, which led to a very successful call to action. You see in the light blue box there, the 5 key messages from modeled data from the folks at the Program in Global Surgery and Social Change and their partners in different parts of the world at that time with John Muir as lead author, stated that 5 billion people lack access to safe, affordable surgical and anesthesia care when needed. 143 million additional procedures are needed yearly to fulfill that unmet need. And about 33 and 81 million, respectively, face impoverishing and catastrophic expenditure as a result of surgical care yearly. And that an investment of $350 billion upfront is in fact affordable and in fact is achievable and would replace a $12 trillion cost of inaction if we didn't in fact, start to implement plans to take action in populations with respect to timely, quality, and affordable surgical healthcare. So you can see that that's a cost of inaction. And then ultimately, surgery is an indivisible, indispensable part of healthcare. Now, just keep in mind, 5 billion people lacking access to safe, quality, and affordable surgical healthcare. There was some modeling that Mark Schrein, Blake Alkire did at that time that were built into this publication to come to these 5 key messages. And that was largely due to the percent of disability adjusted life years that were due to non-communicable disease. You can see across the globe that non-communicable disease, that being surgery, obstetrics, anesthesia, and other type of surgical healthcare services, were pretty profound. So disability adjusted life years as a result of not having surgical healthcare is one thing. Disability adjusted life years as a result of having what would be intervened upon by surgeons, obstetrics, and anesthesia is also a whole other category of non-communicable disease that's prevalent across the globe. Now, let me just take you on a little bit of a path through what the patient experiences that allows us to come to that conclusion that 5 billion people lack access to surgical, obstetric, and anesthesia care that is timely, quality, and affordable. And this allows us to set a foundation for what we interpret to be our action, which is surgical system situational analysis. If you look all the way to the left, this is a schematic that really addresses those 6 indicators and also addresses the 3 parts of the healthcare system that we talked about earlier, which is the surgical healthcare system prepared for the patient and population? Is the surgical healthcare system delivering quality service to the patient and the population? And is the system, surgical healthcare system that is, cost protecting the patient and the population if the population does in fact need surgery, obstetrics, or anesthesia care? Now look all the way to the left with that population, that green arrow should have just populated. Let's have a hypothetical situation here that Blake and Mark put together in that model to understand that 5 billion people lack access to surgical healthcare. If you throw the population through the surgical healthcare system, do they have timely access to surgical care? Do the facilities and do the physicians have the capacity to care for them if they enter the surgical system? Is the provision of surgical healthcare provided to them safe? In fact, does that mean that they have a quality healthcare with a good outcome? And thirdly, is that surgical healthcare service that the patient does in fact receive if they enter the system affordable? And that's what we come up to say that yes, a patient does have timely, safe, or quality, affordable surgical healthcare. And then you can imagine through models that, 1 times 2 times 2 times 3 equals some proportion of the population that has a yes. But if you look at the other scenario going all the way back to the left, you see the number 1 that just populated. If the population or the patient enters the system and they can't reach a facility in a timely fashion, they can't reach a facility in 2 hours, then boom, that patient is declared to have no access. They become part of that 5 billion across the world. The second number 1 there, if the facility or the surgeons, anesthesiologists, and obstetricians aren't available, then boom, there's another reason for no access. If a third scenario is that the facility does not perform a safe operation, or the surgeons, anesthesiologists, and obstetricians don't have the resources to provide a safe operation, that would be the third scenario for no access. And then fourth, let's say that they were able to reach the system, they were able to have a surgeon care for them, it was a safe operation, but with that operation put them into catastrophic or impoverishing expenditure, and then therefore they were poor after the operation. Well, what's really the point of that? And then that would be that other factor in not having access. So then those patients cumulatively lead to this 5 billion people that lack access to surgical healthcare because the surgical system is inadequate. So we diagnose the surgical system through this situational analysis. Now, how did we do that with our Colombian colleagues and the Colombian Ministry of Health? Well, in this overview, let's look at that first part, surgical system preparedness, right? Surgical system preparedness, again, is indicator 1, which is how much of the population has 2-hour geographic access to a facility And also, what is the number of surgeons, anesthesiologists, and obstetricians able to care for that population once they get to a facility? So that's the system preparedness. Now, in Colombia, indicator 1 2-hour geographic access, as we mentioned. We looked at all the facilities that were bellwether facilities. That means that those facilities are able to provide laparotomy, C-section, and open fracture washout and reduction, because that's in fact the bigger predictors of mortality across the world. So we looked at all facilities over to the right there, the number of institutions that are bellwether capable. That in other words, they're able to perform timely, quality, and affordable laparotomy, C-section, and open fracture and reduction. We quantified the number of institutions. Then I should say that we quantified those number of institutions through a RIPS database, which is all of the procedures that were performed at those particular institutions capable of performing the bellwether procedures. Then we took those facilities, we located them and mapped them. We put them through different methodologies, including ArcGIS, which is a geospatial mapping methodology. And then we calculated drive times through another software package called Esri. And then we conducted 2-hour drive time envelopes for the entire population to those facilities capable of performing all 3 of those operations to declare those facilities bellwether facilities. As you can see over to the right, the map just changed, and this is that 2-hour drive envelope. So the entire country of Colombia in that light yellow, as opposed to the darker yellow there, the light yellow indicating that that is the geographic landmass without 2-hour access to surgical care. We mapped that 2-hour drive time, and then we overlaid that on the population density map, which then led us to this geospatial mapping figure to the right. Well, what does that mean? Well, there is a disparity that the population is experiencing that we can calculate from that that number of the percentage of the population not able to get to a facility and not able to get to a surgeon's, anesthesiologist, obstetricians capable of performing those procedures. The geospatial analysis that we performed, now over to the right, we can look all the way down to the departamento and the municipio level in Colombia, which is essentially the zip codes as compared to North America. And then we can have a legend to suggest what percentage of the population and what percentage of Colombian citizens are not within 2-hour drive time to a facility and to a surgeon, anesthesiologist, and obstetrician. Now you can imagine a minister of health looking at this image of their own country. This is very granular information about where to start to plan some interventions. So through some, for the sake of time, some analysis I'll leave out. At least 7 million people in Colombia, roughly 15% are unable to reach an appropriate facility for emergent surgical services, that being laparotomy, C-section, and open fracture. Now, we did the same thing with surgeons, anesthesiologists, and obstetricians density. And with these pieces of information, 2-hour drive time, and also calculating it to a more descriptive percentage, these are the percentages over to the right of the population that does not have that access. So these geospatial maps allow us to overlap variables on top of each other to say what's going on with the population with respect to how the surgical system is preparing for them and preparing for them to deliver timely, quality, and affordable surgical health care. Now let's look at surgeons, anesthesiologists, and obstetricians density. And if you remember, that indicator is that would be a number of 5,000 per 100,000 population. In order to do this, we queried a RIPS database in Colombia, which is a database that logs all of the specialists' information. We looked at then different disciplines that we interpreted to be necessary for an emergency and essential surgical healthcare package, that being surgeons, anesthesiologists, and obstetricians. And then we discussed with the professional societies their knowledge and awareness of their surgeons, anesthesiologists, and obstetricians within their own societies to provide a provider density cross-check, that being the Colombian Surgical Society, and SCARE, which is the Anesthesia Society. And then we had data for 2016 and 2018 as population estimates, so census in other words. And then we calculate the SAO, roughly 13.7 per 100,000 population of SAO. So as you can see, that falls short of what the Lancet Commission on Global Surgery recommended to be 20 for low-income countries, 30 roughly for middle-income countries, and greater than 40 for high-income countries, Colombia being an upper middle-income country. So even we have some provider disparity here with respect to Colombia being an upper middle-income country, even lower than what a low-income country is expected to have, which is 20 per 100,000. We did the same thing with our geospatial methodologies. And this is the map that we can come up with when we look at SAO per 100,000. Now, as you can see, something really pops up interesting here. Colombia is divided essentially more or less between a northwestern part of the country and a southeastern part of the country that is much, much more rural than the northwest portion of the country that's urban. But there are pockets that are dark green, which means that there are greater than 15 SAO per 100,000 population. So that's the municipios and departamentos, or the zip codes, that have a good representation of surgeons, anesthesiologists, and obstetricians. Now you can look at all of the other lighter areas that represent 0 surgeons, anesthesiologists, and obstetricians through the methodologies that we were querying the surgeons, anesthesiologists, and obstetricians. So you can see that huge geographic disparity in what providers are available for the population to then be part of that preparedness that the surgical system is anticipated to deliver. In conclusion, 80% of municipios, which is the small, right down to the zip code level, with 16 million people, lack a surgeon, anesthesiologist, and obstetrician provider. They do not have a surgeon, anesthesiologist, and obstetrician in their more or less zip code. Now, the most socioeconomically disadvantaged municipios, that means most socioeconomically disadvantaged zip codes, lack SAO. Now, that in fact worsens any kind of disparity with respect to socioeconomic status and the relationship to surgical healthcare services. So these were pretty good conclusions that we reached to start to talk about the disparities in geography with respect to healthcare services provided. Okay, Colombian surgical system delivery. What does that mean? Well, we talked about indicator 3 being the total operative volume, anticipated to be 5,000 procedures per 100,000 population. So how did we evaluate this in Colombia with our partners? COOPS codes, which are equivalent to CPTs in North America, which is procedural codes. We queried the COOPS database for all procedures representing what would fall into C-section, laparotomy, and open fracture and reduction, okay? Most likely to be done in an OR. It was roughly 12,000. Now RIPS, again, was queried for all COOPS codes identified. So we were essentially putting together the billing that the healthcare service providers submitted, along with what procedures they were submitting for reimbursement. So we used more or less claims data to make these conclusions and draw these associations between providers and what they're doing and where. Now, there's about 1.5 million procedures being done across Colombia. And what that means is when we look down into the national, departamento, and municipio level, what is the total operative volume calculated that then delivers down, that discerns down to the more granular level, not the national level. We use geospatial analysis to tell us what our total operative volume was that was performed. And again, you note, it's more or less the same pattern. The operative volume is predominant in the northwestern part of the country. Again, not just a large generalization of northwest versus southeast, but even dialing down into departamento and municipio level, you can see that the operative volume also varies depending on what is the zip code, more or less. And then we were able to say that the mean national total operative volume is roughly 3,000 per 100,000 population. Now note, 5,000 per 100,000 procedures were recommended by the Lancet Commission on Global Surgery. for a low-income country, and we're talking about a upper middle-income country here. So there are some disparities with respect to the number of volume of surgeries that are being suggested given the population's need, and that's from epidemiologic data across the world. Now, indicator 4, post-operative mortality rate. So the people that are undergoing surgery is really sort of part of that service delivery. How's the system doing with this second indicator of what allows us to discern surgical service delivery, the system's surgical service delivery? Again, we looked at the RIPS database. We queried them for all surgical procedures performed in 2016. The RIPS output cross-referenced with the Ministry of Health mortality database. So then all people having surgery, we were then able to cross-reference and indirectly determine how many of those people were dying after surgery within 30 days. This being a little bit different than the Lancet Commission on Global Surgery definition, because the Lancet Commission on Global Surgery focused on inpatient, less than 30-day mortality. We focused on all mortality within 30 days of any procedure, whether they were in the hospital or discharged. We filtered duplicate entries given the databases. And then we calculated a 30-day mortality for any operative volume conducted. And we reached a mean of a 0.71% with a standard deviation there for all the procedures being performed in Colombia, which you remember was about 1.5 million procedures. Now, the geospatial analysis, again, was performed, and we have a broader picture here of percentage of postoperative mortality rate. But if you look at this as well at the departmental level, that's why the granular detail is less specific here. We do have other maps for the municipios, which is the smallest granular level of detail according to zip code. You can look at departmentos more or less as regions, so to speak. But the percentage of postoperative mortality rate here also has a very similar pattern to some of the other indicators we're looking at. So these disparities are essentially across the surgical system and the provision of timely quality healthcare services. And we'll talk about affordability in just a minute. But note here, there's some real consistencies with what the Colombian Ministry of Health has noticed as well. If you look all the way to the left, the most southwest portion of this map, that green, right, represents high postoperative mortality rate. These other areas that are that darker green represent higher postoperative mortality rate. And what we found that was interesting was the higher socioeconomic status population and or geographic areas were suffering higher postoperative mortality rate. Now, you can think to yourself, why would that be? Well, it's probably because, again, the indicator 4, postoperative mortality rate, is non-risk adjusted as defined by the Lancet Commission on Global Surgery. This provides a large aggregate of all-cause non-risk adjusted postoperative mortality rate. So probably what's happening is in the higher socioeconomic status communities, and the hospitals that fall within those higher socioeconomic status communities are probably accepting higher risk patients. And that really just makes the point of the importance of being able to move from this type of aggregate cross-sectional or even ecological data down to the more granular detail that then would consider that adjusted postoperative mortality rate. Okay, lastly, surgical system cost protection. Wanted to point out, since 1993, Colombia introduced a social reform and a commitment to their social well-being of their population to provide a universal health insurance system. Today, 97% of Colombia's population is insured, okay? Now, there are some nuances. Just because you have insurance doesn't necessarily mean you have affordability. That doesn't mean that folks don't have out-of-pocket payments, indirect costs of healthcare, like the cost of traveling to a hospital or a facility. So looking into impoverishing and catastrophic expenditure considers those costs as well, not just having insurance, but some of these other payments that then lead to families being impoverished and enduring catastrophic expenditure as a result of having surgical healthcare. Now, this is important when we start to understand the socioeconomic disparities in Colombia as a baseline that informs access to healthcare, okay? And especially access to healthcare that's essential. The way that we looked at this and considered this in our analysis is that there's a disparity that's more or less related to the insurance regimes. So in Colombia, there's 3 different insurance regimes. There's an insurance regime for the higher socioeconomic status, which is the contributory regime. That means that payroll taxes are higher for the population that has higher income. Therefore, they contribute more to the universal health insurance system for the rest of the population. But then there's this other category of what is subsidized regime, which means that less payroll taxes are responsible for that portion of the population. And that portion of the population represents lower socioeconomic status representations of that particular population. Now, how much of the population that is a subsidized regime over the total, we were concluding that of the lower socioeconomic status people, they then in fact had this subsidized regime. And because of that, we tried to understand that if the lower socioeconomic status regime did in fact have differences in the way that they would access healthcare and their out-of-pocket payments would be different. The question really is the lower socioeconomic status experiencing impoverishing and catastrophic expenditure worse than what the higher socioeconomic status would? And so we found that the percent subsidized across Colombia that was in fact part of that subsidized regime relating to a lower socioeconomic status had these patterns over to the right that we geospatially mapped as well. So with that, if you look at the legend, in those darker green areas, greater than 90% of the population is this subsidized population. So there is a socioeconomic disparity that we were able to geospatially map as well for the purposes of considering who is at risk in the population geographically that relates to their socioeconomic status and relates to the insurance regime they're in. And from that, we concluded that half of the population is at some financial risk, giving out-of-pocket payments and indirect costs. The impact of indirect costs can be anticipated to be felt by a disproportionately large segment of the population. Half of the population, and what is an interesting conclusion is a larger portion of that subsidized regime is experiencing impoverishing and catastrophic expenditure. So what we're potentially talking about is making the poorer portion of the population, in fact, more poor as a result of surgical healthcare once they enter the surgical healthcare system. Now, the Colombian socioeconomic disparity has a lot to do with why people find reasons not to access the healthcare services in Colombia. And if you look across the 4 quartiles here, no matter where you were located in Colombia, all 4 quartiles of socioeconomic status, that being even broader breakdown of those 2 regimes that I mentioned, which are the subsidized regimes and the contributory regimes, no matter what quartile you were in as far as income, all 4 quartiles said that money is an issue for accessing healthcare services. So no matter, despite the 97% being insured, and despite the 2 regimes of insurance status, everyone is saying that cost is an issue for accessing the surgical healthcare system. Now, other factors like lack of time and poor quality of the healthcare system based on their perspective were other reasons. But I just wanted to raise the point that everyone is concerned about the cost of accessing the surgical healthcare system. Now, to look a little bit finer at what I just explained to you, the way that we did that work was to compare what data from a 2007 National Health Survey mapped on top of that geographic socioeconomic status and the regimes. we are laying variables on top of each other to say that they're associated. From this 2007 National Health Survey, people were queried for healthcare cost data. It was qualitative feedback from the population, a selected portion of the population. The average indirect surgical costs were calculated from that query of that National Healthcare Survey, and the proportion of the population at or below the poverty line was calculated, and their annual income in proportion to indirect costs were calculated. So, in conclusion, indicator 5, the population at risk of impoverishing expenditure, based on 2007 data, which is the latest healthcare cost survey, the latest healthcare surveillance survey, roughly a third of people lived below the poverty line in Colombia. When indirect costs were incurred in that survey year, this proportion increased to over 40%, and therefore the risk of impoverishment is 6% of the population, even with 97% of the population insured. Thank you. For those already living below the poverty line, the poverty gap increased by 4%. So this is clearly, is furthermore making the point earlier that we're making poorer people poorer, and 10% of the population is at risk for new or worsening impoverishment. Indicator 6, the proportion of the population living in households whose indirect costs for surgical healthcare services was 10% or more of the annual household income was calculated. This is another definition that's been used to calculate catastrophic expenditure, using the fundamental definition of indicator 6. Catastrophic expenses were experienced by 20% of the population. So in conclusion, what we could do with this data, indicators 1, 2, 3, 4, 5, and 6, as well as understanding the surgical system preparedness, delivery, and impact or cost protection, all the way from New Jersey with our partners in Colombia, we can start to say how the Ministry of Health has assessed their population prior to this work. There are 4 areas, municipios, identified as problematic areas with respect to 2-hour access. So the Ministry of Health was also considering what the problematic populations would be. And we compared what they came up with in their 4 municipios to what we concluded to the left, which are the municipios lacking access and how many people. This is of the total roughly 1,100 municipios. So what we were able to do with the Ministry of Health is say, hey, through the 6 indicators and through surgical system situational analysis, we are conducting methodologies that really support the way that you're looking at the populations, and how can we come together to address these disparities with respect to the populations that lack access to timely, quality, affordable surgical health care. Other considerations, okay, are 2-hour access percentages, Cali being one of the more populated areas, one of the more wealthier industrialized areas of the country, compared to Beneventura. Beneventura being sort of on, the other way around, Cali being one of the more impoverishing areas and Beneventura being one of the more wealthy areas. You can see the discrepancy there with 2-hour access. Operative volume is reversed. SAO density is reversed. Socioeconomic status, that relationship there when we start to consider the subsidized and contributory regimes. So this data allows you to make associations with respect to how the surgical system is addressing timely, quality, and affordable surgical health care. In summary, we're talking about access, that being preparedness to the surgical system and providers, surgical system delivery, and surgical system cost protection. So what we have now at the end of this surgical system situational analysis is a surgical system dashboard that more or less calculates all 6 indicators for the entire 50 million population for Colombia at an ecological level to say that your Lancet Commission on Global Surgery indicators are calculated. Therefore, 85% can get to a hospital. 13 per 100,000 population, SAO, serves the population. 3,000 procedures from what's recommended, 5,000 procedures, are conducted. 0.7% postoperative mortality rate. This, by the way, is a very good postoperative mortality rate, considering how much disparity exists with the location of the population and the providers and their locations. Post-op mortality rate is not standardized across the world. That's the work of some other folks. That will be helpful ultimately to compare, to have a systems comparative analysis between Colombia and some other countries. Again, we're getting down to the data that matters. And then from the respective cost protection, roughly 20% of the population is at risk for impoverishing expenditure. That means that 40% of their household expenditure is used to pay for healthcare services that they need as they enter the system. And roughly 10% of the population is experiencing catastrophic expenditure as a result of having healthcare services that they need as well. So this is a complete assessment of the population with respect to the surgical system, ability or diagnosing the surgical system to really understand what is a patient's and or population's access to timely, quality, and cost protected care. Key message: the poorer the individual, it seems, the lower the likelihood of being within 2-hour access of a bellwether procedure. Bellwether facility being able to provide that service through their surgeons, anesthesiologists, and obstetricians providers. Key message 2, Colombian surgeons, anesthesiologists, and obstetricians. I left out the nursing in this lecture, but those providers appear to be working at or beyond capacity while maintaining a relatively low mean postoperative mortality rate. Key message 3, with 0.69 times the minimum SAO density and 0.14 times predicted needed nursing ratio, which I left out, the observed total operative volume is 0.62 times the target volume of 5,000 procedures. So we're just putting that together in our analysis and our results. With that, I'd like to thank many folks in Colombia and many folks at Rutgers, many folks at the Program in Global Surgery and Social Change, and the acknowledgements extend across many institutions in order to be able to do the surgical system situational analysis. And I'd like to entertain any questions at this time that you may have. But what I'll do is I'll pick up my phone to answer those questions, and maybe Anusha can translate some of those answers in order for me to make my flight. Thank you, guys.